Good morning, everyone. So I'm sure all of you see such patients, such children walking into your OPD brought by their anxious parents with the concern that my child is walking with an awkward gait. And that time in your busy practice, you have to decide whether this is something, a variation of the normal physiology, or is it something pathological that we are looking at. So let us try and analyze this with the help of few examples. So the common gait deviation children which we present to your OPD are the ones with angular problems, and especially bowing in toddlers. So this is a 1.5-year-old female child who walks with bowing of both legs. Bowing appears to be relatively symmetrical, involving both femur and tibia. The child has normal stature and there is no lateral thrust with ambulation. So whether this is normal or no, to know that you must know the normal development of knee alignment. So each newborn is born with little bit of varus. So there's about 10 to 15 degrees of varus up to about 1.5 years. From 1.5 to 2 years, the knee appears neutral. Then it goes into more valgus up to 2 to 4 years. And finally, at 4 to 7 years, there is decrease in valgus to the normal adult alignment of about 7 to 8 degrees. So this child had come with an X-ray, so that also showed that though the tibiofibular angle was more than 10, so there was varus, but rest of the things were normal, and this child is having physiological bowing, and you need not do anything active but just observe and counsel the parents. But every bowing, let me tell you, is not physiological. Like this child, a 3-year-old male, who again is walking with bilaterally symmetrical bowed legs. There is bowing of femur and tibia, but he's walking with a wide base and waddling gait. And if you look at the child as a whole, he has signs of active rickets. And his X-ray also confirmed, and biochemical parameters confirmed that this was a child with rickets, and you need to intervene and not neglect. Another child, about 1.5-year-old female child, a little obese. She had a history of started walking early. Here there's asymmetrical angular alignment. If you see closely, there is more of varus at proximal femur, proximal tibia, and there's a subtle lateral thrust while the child is walking. Looking at the X-ray, there is varus deformity of proximal tibia, there is medial beaking and downward slope of the proximal tibia metaphysis, and the proximal tibia metaphyseal diaphyseal angle is more than 16, so this child is a case of infantile tibia vara and you must intervene early. Coming to knock knees, the other deformity, this is a 10-year-old female child walking with bilateral genu valgum, and the intermalleolar distance is 12 centimeter. So if you remember the knee alignment at this age, this much amount of valgus is beyond normal physiological genu valgum, and this needs to be addressed, and this will be covered in detail by Dr. Swapnil Keni. Coming to rotational problems, so just we saw about the angular deformities leading to gait deviations. There are certain rotational problems which also lead to an awkward gait. So this is a 4-year-old female child walking with in-toeing, walks with patella and feet pointing inward. There's a negative foot progression angle. She has about very clumsy circumduction gait. And on examination, she has excessive femoral internal rotation. If you look at the X-ray, the femur is in anteverted. So is it normal for her age? So just as we saw the angular alignment, we must know what is the normal development of lower limb torsional profile. So at birth, we know that femur is more anteverted, about almost 30 to 40 degrees, and tibia is also in torsion about 5 to 10 degrees. Almost by 8 years, the tibia goes, both femur and tibia gradually externally rotate, and by 8 years, the tibial external rotation is about 10 degrees, and by early adolescence, you achieve your normal femoral anteversion of 10 to 15 degrees. So if a child walks with in-toeing at about 4 to 7-year-old school-going child, most of the time that is because of femoral anteversion, and they typically give the history of W-sitting. In toddlers, it may be because of tibial intorsion, and in infants, it may be because of the metatarsus adductus, and majority at that age are considered physiological and resolved. So this can be known by the test where the rotation is coming from the hip rotation assessment, thigh foot angle, bimalleolar axis, and so on and so forth. So considering the out-toeing gait, so this is a 10-year-old female walking with out-toeing, and on examination, she is found to have flexible pes planus. And this is confirmed again by the X-ray. So this again is a out-toeing gait and the cause for that. And as we saw in in-toeing, the out-toeing also needs to be evaluated by considering the rotational profile because there are certain other causes like some neuromuscular disorders or slip capital femoral epiphysis also lead to out-toeing. But you must understand that always in children gait are not the physiological variations. You may have certain other disorders which can affect gait, and you should not neglect them. So this young girl walking with an unstable short limb gait, on X-ray and examination found to have developmental dysplasia of the hip, and this child walking with Trendelenburg gait and with restricted hip range of motion on X-ray had developmental coxavara. So to answer the question which we posed in the beginning, you see patients coming to your OPD. What should be your right approach to a child walking with an awkward gait? You must be familiar with the normal development of the angular and the rotational profile of the lower limb. Should have close observation not only of the gait, but a detailed musculoskeletal examination is important in order to differentiate whether it's a physiological variation and a normal developmental gait problem, or is it pathological. Parental reassurance and regular follow-up is essential if it's a normal developmental gait anomaly, but early recognition of pathological gait and timely intervention is necessary in order to intervene early and get the best outcome. Thank you.